Welcome to the deep dive. We take a whole stack of material research papers, articles, notes, and basically pull out the key insights for you. And today, we're tackling something pretty much universal, or at least universally known, that awful feeling of nausea and vomiting. Just really unpleasant. Nobody wants it.
Yeah, that feeling where even thinking about food is just,
Oh, yeah.
ooh. So that's why we're diving deep into, well, the surprisingly complicated world of antiemetic drug classes. Our mission really is to get past the jargon, uncover how these different meds actually work, what makes each one special, and importantly, what you need to watch out for. The goal is you'll leave understanding these drugs much better.
It really is fascinating
We can be-
because the goal seems simple, right? Just stop the nausea. But the ways the body gets there, incredibly varied, sometimes really surprising, actually. And the research and guidelines we've looked at for today, they really shine light on these complex mechanisms. Okay, yeah, let's unpack this. Starting with maybe a less obvious one for nausea, butyrophenones. Specifically haloperidol and droperidol. We saw their mechanism described as similar to phenothiazines. What does similar really mean here? Is it just like a minor variation, or is there a key difference?
That's a great point. Similar definitely doesn't mean identical. They do share features, like blocking dopamine receptors in the brain's chemoreceptor trigger zone. That's a key spot for vomiting. But their chemical structures are distinct, and that means they might bind to those receptors, well, slightly differently. It's subtle, but it matters.
And that subtlety seems to have real clinical impact. We saw research saying they're at least as effective, maybe even superior sometimes to phenothiazines. It also mentioned they're an initial alternative when a phenothiazine fails. So is it like a backup plan or sometimes the first choice?
It's definitely a crucial alternative. If the first drug doesn't work, having another option that works just a bit differently can be exactly what a patient needs. But like anything powerful, there are side effects. Sedation, hypotension, though maybe less hypotension than with phenothiazines, according to our sources, and also extrapyramidal symptoms.
Extrapyramidal symptoms, right? Can you just quickly break down what that means?
Sure. It's basically a group of movement issues, things like involuntary muscle spasms, tremors, or this really intense inner restlessness, akathisia, it's called, can be very uncomfortable.
Yeah, that sounds difficult.
Yeah.
And speaking of difficulties, there's a really critical point about droperidol specifically, that its use has fallen out of favor. Why?
Yeah.
What happened?
Yes. This is such a clear example of why tracking adverse events is vital. Droperidol, specifically, got linked to a pretty serious risk. QT prolongation and torsades de pointe. These are significant heart rhythm problems, potentially life-threatening. So even though it worked, that cardiac risk meant its use as an antiemetic got pulled back significantly. The risk just wasn't worth it in many cases.
Okay, that makes sense. Let's switch gears then. What about a drug maybe more familiar, but maybe not for nausea? Lorazepam. It's a common benzodiazepam. But here's the kicker we found. On its own, as a single drug, it apparently has minimal antiemetic activity. So what's the deal? Why are we even talking about it if it doesn't really fight nausea directly?
Right, and this is where lorazepam gets really interesting. Its value isn't as a primary nausea fighter. It's really about using it in combination with or as an adjunct to other antiemetics. Think of it less like the main attacker and more like a really important support player. It helps other drugs work better and tackles other issues that contribute to the problem.
Ah, okay, that clicks. And the sources highlighted a few ways it does that. First, this thing called anterograde amnesia. Apparently, it helps stop anticipatory nausea and vomiting. Like it helps you forget the bad experience.
Exactly. It's actually quite clever, especially for things like chemo, where just the thought or, the smell of the hospital can trigger nausea before anything even happens. It helps break that cycle.
Makes sense. Then obviously the relief of anxiety. If you're feeling sick, being less anxious has got to help, right?
Absolutely. A clear benefit.
And finally, it helps manage akathisia, that restlessness you mentioned earlier, which can actually be a side effect of other antiemetics like the phenothiazines or butyrophenones. So lorazepam kind of cleans up that side effect.
Precisely. It helps calm that specific side effect down. And looking at its own side effects, amnesia, sedation, hypotension, maybe some perceptual issues, urinary incontinence, the research points out something unique. It says, note that amnesia and sedation may, in fact, be desirable here, which sounds odd, but in the context of, say, very distressing cancer treatment, being a bit sedated and maybe not remembering everything clearly, that can actually improve the patient's overall experience. It's intentional.
Right, using a side effect to your advantage. Okay, now for something really interesting, olanzapine. FDA approved for schizophrenia, bipolar disorder, psychiatric conditions. But then we found it's used off-label as an alternative agent for preventing nausea and vomiting in highly emetogenic regimens, and even for breakthrough nausea. This feels like a big deal, finding a new use like this. What's going on there?
You're absolutely right. It is a big deal. And it really challenges that idea of one drug, one target. It shows how complex our systems are. A single drug can hit multiple pathways. Olanzapine's strength here seems to be its broad action. It blocks lots of different neurotransmitters, dopamine, serotonin, catecholamines, acetylcholine, histamine, all sorts of things. And since nausea itself involves multiple pathways, hitting it with this broad approach seems to be why it works so well, even though that wasn't its original purpose. It's often clinical observation that leads to these discoveries.
Okay, so broad action equals broad effect. But does it also mean broad side effects? The list we saw included sedation, dry mouth, increased appetite, weight gain, postural hypotension, even QTC prolongation, dizziness.
Yes, those are the more common ones. And then there are more serious potential risks too, links to higher lipids, higher blood sugar, even new onset diabetes. And really crucially, there's a black box warning mentioned for older adults with dementia-related psychosis, an elevated risk of death and stroke-like events. So these warnings are super important, especially for specific groups of patients. You have to be careful.
Wow, yeah. Those are definitely serious considerations. But on the other hand, there must be strong evidence for its effectiveness to justify those risks in certain situations. We saw a phase 3 study comparing olanzapine head-to-head with Previtent, another antiemetic, specifically in tough, highly emetogenic chemo regimens. What did that study actually find? Was it surprising?
It was quite significant, yeah. The overall success rates preventing both acute and delayed nausea and vomiting were pretty similar between olanzapine and aprepitant, which is already impressive. But here's the really interesting part, the nuance. When they looked specifically at patients having no nausea at all, the rates were similar in the first 24 hours, the acute phase. But in the delayed phase, so days 2 to 5 after chemo, the olanzapine group had a higher proportion of patients completely free of nausea. It showed a particular strength in controlling that later lingering nausea, which can be really draining for people.
That's huge, especially for cancer patients dealing with those ongoing effects.
Hmm.
And it seems like this evidence has really influenced practice. We read that an olanzapine-based regimen is now listed as an option in major guidelines, like from the NCCN, for highly or moderately nausea-inducing chemo. That's a pretty strong nod of approval.
It absolutely is. It shows that the clinical evidence was compelling enough to change standard recommendations.
Okay, so let's round things out with our final class, one that gets a lot of attention. Cannabinoids, specifically dronabinol and nabilone. How are these thought to work against nausea? What's the proposed mechanism?
Well, the main idea is that cannabinoid receptors in our body likely play a role in mediating the antiemetic effect. But there are other proposed mechanisms too, like maybe inhibiting prostaglandins or blocking adrenergic activity. It seems like, similar to other effects of cannabinoids, it might be hitting multiple targets.
Right, and the side effects are definitely distinct. We saw things like drowsiness, dizziness, but also euphoria, dysphoria, feeling uneasy or unhappy, orthostatic hypotension, coordination problems, ataxia, hallucinations, and even time disorientation.
Yeah, and it's interesting how some of those, the euphoria, dysphoria, the hallucinations, the time thing, directly relate to the psychoactive effects people associate with cannabis, right? For some patients, maybe those undergoing really tough treatments, some of those effects might actually be seen as okay, maybe even helpful, like a distraction. But for others, they could be really unpleasant or disorienting. So it really comes down to the individual patient.
What a fascinating tour through these different antiemetic classes. It really drives home that there isn't just one way to tackle nausea and vomiting. It's more like this diverse toolkit. Each drug class uses a different biochemical strategy, offers unique benefits, but also comes with really important things to consider: side effects, which patients they suit best. It's complex.
Absolutely. And I think this deep dive really highlights how knowing the why choose this drug over that one, how it works, gives you such a richer understanding than just knowing the what. It really shows the complexity and, frankly, the careful thought that goes into medical decisions. Understanding the details makes the knowledge so much more powerful.
Well, thank you so much for joining us on this deep dive into antiemetics. We really hope you feel more informed, maybe a bit surprised by some of the things we uncovered today.
And maybe something to think about as you process all this, given these diverse mechanisms, the overlapping side effects, the distinct ones, how might future antiemetic drugs be designed? Could we get more selective, target specific nausea pathways better, maybe minimize those unwanted effects? What new combinations or totally new approaches might come out of understanding these details even better?